Here we go. Welcome everybody to the Brain Injury and Domestic Violence Part 1 of 2 series. Next slide. My name is Gabriela Lawrence Soto. I am the Bridges Between Grant Program Manager over at the Massachusetts Rehabilitation Commission. And with me today is Rebecca Thomas, the Director of the Injury Prevention and Control over at the Massachusetts Department of Public Health, as well as Dr. Bree Insulaco, Chief Neuropsychologist at the Massachusetts Rehabilitation Commission. Next slide. We ask that the materials in this presentation remain the property of the statewide head injury program. They may not be reproduced, edited, or distributed without written consent. Next slide. Today, we hope to give you an introduction of the training program and review some of the materials provided. We will describe the grant goals, expectations for the training series, and share feedback from the Department of Public Health survey. We will describe cognitive and physical consequences of brain injury and demonstrate working knowledge of the intersection of brain injury and domestic violence and intimate partner violence. We will discuss some of the barriers to evaluation and treatment with co-occurring brain injury and domestic violence and intimate partner violence. And lastly, review the continuum of brain injury services. Next slide. A little bit about the Massachusetts Rehabilitation Commission. We are an agency that provides comprehensive services to people with disabilities that will maximize their quality of life and economic self-sufficiency in the community. To accomplish this, we do this through several programs in 3 service delivery areas. That is our vocational rehabilitation division, which focuses on employment, our disability determination services, which focuses on determining eligibility for disability benefits such as SSI and SSDI, and then our community living program division, which has programs such as the statewide head injury program and brain injury waivers, our independent living and assistive technology program, transition services, home care assistance programs for individuals under 60, our protective service unit, and our community-based housing program. Now at this time, I would like to invite Rebecca Thomas to talk about the project. Next slide.
Great, thanks so much, Gabby. It's a pleasure to be with you all today for this recording of part 1 of the training series. This has been something in the making for quite a while. I am the principal investigator for the Core State Violence and Injury Prevention Program, which is from the Centers for Disease Control and Prevention to the Department of Public Health. The grant runs from 2016 to 2020, and one of the main topic areas that we're exploring is traumatic brain injury. Back in 2018, I and some of my colleagues met with Gabby over at MRC to talk about synergies between our work and what we could do in the field. The topic about training for domestic violence shelter staff in order to screen and refer individuals who have a brain injury came up as a conversation discussion during that meeting. This is something that we've seen in several other states like Alabama, New Jersey, Nebraska, and many others, but it wasn't something that was taking place in Massachusetts. So we decided to explore a little bit more about what domestic violence shelter staff were up to in terms of traumatic brain injury screening and referral and what their baseline knowledge was. And we found out that you all are very interested in this topic, but didn't necessarily feel like you had the tools at your fingertips to address this. There was a good understanding that folks who experience domestic violence or intimate partner violence do have higher rates of traumatic brain injury, but we're hoping to answer some questions today about what to do with that information. And that's led to today's training and the next series, part 2 of this training as well. We hope you find this information useful and informative, and we're thrilled to have you here paying attention to this very important topic. And with that, I will pass it over to our main presenter today, Dr. Insulaco.
Thank you, Rebecca, and thank you everyone for joining us today for today's presentation. The statewide head injury program has been providing brain injury trainings to providers across Massachusetts for many years. We were very excited and really appreciate the opportunity to participate in a training collaboration with DPH that focuses on not just brain injury awareness, but also the intersection of brain injury and domestic violence. A few notes about the content. While we do understand there are differences in definitions for intimate partner violence and domestic violence, we will be using these terms interchangeably for the purpose of today's presentation. Additionally, there are several types of acquired brain injuries that individuals can sustain, and we will give examples of each, but we'll focus on traumatic brain injury in today's presentation. That being said, the consequences of brain injury and strategies and accommodations presented today generalize to all types of brain injuries and are not limited to working with individuals with traumatic brain injuries. We will begin with a review of basic definitions for TBI and intimate partner violence or domestic violence. A traumatic brain injury is a disruption in the normal function of the brain that can be caused by a bump, blow, or jolt to the head or penetrating head injury. A traumatic brain injury is one that is caused by an external force, and we will note some of the ways TBIs can occur later in the presentation. Intimate partner violence or domestic violence includes 4 types of behaviors by a current or former partner or spouse. These are physical violence, sexual violence, stalking, and psychological aggression. These behaviors can occur together, and both physical and sexual violence place individuals at increased risk of sustaining a brain injury. Physical violence is when a person hurts or tries to hurt a partner by hitting, kicking, or using another type of physical force. Sexual violence is forcing or attempting to force a partner to take part in a sex act, sexual touching, or a non-physical sexual event such as sexting when the partner does not or cannot consent. Stalking is a pattern of repeated, unwanted attention and contact by a partner that causes fear or concern for one's own safety or the safety of someone close to that individual. Psychological aggression is the use of verbal and nonverbal communication with the intent to harm another person mentally or emotionally and/or to exert control over another person. The national and state data noted on this slide are from the CDC's National Intimate Partner and Sexual Violence Survey, with most recent Massachusetts data from 2010 to 2012. In the United States, prevalence rates indicate that approximately 1 in 4 women and 1 in 10 men have experienced contact sexual violence, physical violence, and/or stalking by an intimate partner. A little over 1 in 3 men and women in the United States have experienced psychological aggression. In Massachusetts, approximately 26% of women have experienced physical violence by an intimate partner, and approximately 15% have experienced sexual violence. These numbers for men are approximately 30% and 10% respectively. With our discussion on high-risk populations, we want to strongly emphasize that any person, regardless of their background or demographics, is at risk for domestic violence. However, research shows that the adverse effects of intimate partner violence is more prevalent in certain groups. Those groups include women, particularly those that are single, separated, or divorced, adolescents and young adults, people of color, immigrant women, and lesbian, gay, bisexual, transgender, or gender nonconforming individuals. With regard to race and ethnicity, more than 4 in 10 non-Hispanic Black women or American Indian Alaska Native women experienced rape, physical violence, and/or stalking by an intimate partner in their lifetime. 1 in 2 multiracial women, 1 in 3 non-Hispanic white women or Hispanic women, and 1 in 5 Asian or Pacific Islander women also had these experiences. Highest prevalence rates for men were also indicated for multiracial men, American Indian Alaska Native men, or non-Hispanic Black men. Another population that is at higher risk is the LGBTQ community. Approximately 6 in 10 bisexual women and 4 in 10 bisexual men, 4 in 10 lesbian women and 1 in 4 gay men, and 1 in 3 heterosexual women and more than 1 in 4 heterosexual men reported experiencing rape, physical violence, and/or stalking within the context of an intimate partner relationship. Overall, bisexual women experienced a significantly higher prevalence rate of these types of violence as well as a higher prevalence rate of experiencing at least one form of severe physical violence in an intimate partner relationship. Research also indicates that women experiencing poverty experience domestic violence at higher rates, and studies show that among mothers with children experiencing homelessness, more than 80% had previously experienced domestic violence. Domestic violence can be a primary cause of homelessness for women and children as families attempt to leave an abusive situation or in cases of eviction due to abuse in the household. Women with low or no incomes may lack safe and affordable housing options and may remain trapped in an abusive relationship with no financial resources and limited options. Immigrant women and girls in the U.S. are twice as likely to experience domestic violence than the general population. They are also further at risk as they are less likely to leave their partners that have perpetrated violence. Potential reasons may include lack of financial resources, isolation, fear of deportation, and fear of losing custody of their children. The Massachusetts Department of Public Health has been able to provide data to us for the purposes of this presentation. As mentioned in the previous slides, the adverse effect of intimate partner violence has been shown in research to be more prevalent in certain groups, including adolescents and young adults and women of color. Massachusetts data related to TBI-related hospital stays and emergency room visits shows that for non-fatal, assault-related hospital stays associated with the TBI, the highest rate of hospital stays was among patients aged 25 to 44, and the highest rate for emergency department visits was among patients 15 to 24, followed by those between 25 to 44. This data highlights non-fatal assault-related hospital stays associated with TBI by race and ethnicity. This data indicates the highest rate for both hospital stays and emergency room visits was among Black, non-Hispanic patients, followed next by Hispanic patients. There is a similar trend in the data when looking at age and race ethnicity related to TBI-related homicides among females. The highest rate of TBI-associated homicides was among females aged 25 to 44 and among Black, non-Hispanic females, followed by Hispanic females. Lastly, we have data that examines TBI-related homicides among females by circumstances and perpetrator. We see that 47%, nearly half, of TBI-associated homicides were related to intimate partner violence. 40% were killed by a current or former intimate partner, and another 39% were known to the victim. While we have shared many statistics on domestic violence so far, there is a known increased risk of brain injury with DV populations. There's still limited research examining the intersection of these fields compared with other populations. For example, there's been increased media reporting and research related to sports injuries and brain trauma, but it's relatively uncommon to hear about brain injuries and domestic violence outside of the particular settings that we work in. Though there is limited available research related to the intersection of DV and brain injury, available studies indicate more complex outcomes for individuals experiencing both brain injury and DV compared with DV alone. Individuals often have a greater number of symptoms, increased number of mental health and medical diagnoses, and more difficulty accessing resources. There is significant importance in providing awareness training for direct care providers and staff working with both of these populations. Increasing brain injury awareness for individuals supporting and working with DV populations can lead to better screening and ultimately increased identification of injuries and appropriate resource referrals. Brain injury providers will also benefit from DV awareness training as it will enhance their evaluation and treatment of individuals, and again with the goal of getting individuals the most appropriate referrals and resources that we can. Given the current pandemic, this training is a particularly timely issue with the additional constraints of a new normal that includes quarantining within one's home, reduced and/or limited social interactions, increased financial instability, and increased mental health and medical issues. In the next slides, we'll highlight the intersection of brain injury, domestic violence, and substance use disorders. As mentioned earlier, we're going to focus on traumatic brain injury in this presentation, but we will review the other brain injury categories. Generally speaking, an acquired brain injury is an injury to the brain which is not hereditary, congenital, degenerative, or induced by birth trauma. Essentially, an acquired brain injury is an injury to the brain that has occurred after birth. It's not something you were born with, such as a genetic disorder that impacts your brain function. Examples of brain injuries that are non-traumatic include injuries resulting from infectious disease, such as encephalitis, brain tumors, vascular injuries such as stroke, neurotoxin exposure, such as that seen with lead poisoning or substance use, and metabolic disorders such as incidents resulting in anoxia or lack of oxygen. A traumatic brain injury is defined as an alteration in brain function or other evidence of brain pathology caused by an external force. A TBI is one type of an acquired brain injury. The diagram indicates examples of causes for TBI. In our field, we may talk about unintentional and intentional causes of brain injury. Unintentional causes include accidents such as falls that result in someone getting a strike to their head, motor vehicle accidents where someone may have a whiplash injury, and sports and work-related injuries. Intentional causes occur due to events such as military combat, such as blast injuries, homicide and suicide attempts, and of course, domestic violence and other physical assaults. Traumatic brain injury is the leading cause of brain injuries. Last published US numbers in 2014 from the CDC indicate 2.87 million TBI-related emergency department visits, hospitalizations, and deaths in the US. As noted previously, a traumatic brain injury is caused by external mechanisms or an outside force that causes damage to the brain. There are several TBI subtypes. A closed head injury is more common and does not involve a break in the skull. It often occurs with falls or motor vehicle accidents. A penetrating head injury is an injury where there is a break in the skull, such as a bullet piercing the brain. A crush injury is sustained by forces occurring when the head is stationary and pinned against a rigid structure. Force is often applied more slowly to the head with these injuries and therefore can produce a different pattern and type of injury. These injuries are often seen in industrial accidents. A blast-related TBI is something we see when individuals have been exposed to an explosion, such as veterans who have been exposed to IED blasts, or civilians exposed to explosive devices in a war zone or through terrorist attacks. What are the most common risks for brain injury with domestic violence? There's a risk of TBI due to a penetrating head injury, such as a gunshot wound or knife or blunt object penetrating the skull. With a penetrating injury, we often see very focal damage, meaning specific areas of the brain are directly impacted due to the location of the injury. There's also a TBI risk due to closed head injury, particularly related to physical and sexual assaults. The head and face are common targets in physical assaults, often resulting in head, neck, and facial injuries. As a result, a domestic violence survivor may have specific, localized damage or diffuse, widespread damage due to bleeding, stretching, tearing, and swelling of brain tissue. We can see these injuries occur when a perpetrator of violence strikes the individual's head with an object, smashes their head against a wall, pushes them downstairs, or violently shakes them. Another type of brain injury that is important to highlight is the risk of brain injury due to an anoxic or hypoxic event, meaning an event where the individual has decreased or no oxygen for a period of time. This may occur during strangulation, intentional drowning, and attempted suffocation. These events can result in widespread and significant brain damage, depending on the amount of time the survivor is without oxygen, or in the case of repeated events of this nature. Domestic violence can be associated with many negative health outcomes. Survivors of violence are at a higher risk for mental illness, suicidal behavior, and for developing addictions to substances including alcohol, tobacco, and drugs. In addition to a possible brain injury, a DV survivor may struggle with trusting others, fear for personal safety, have interpersonal difficulties, anxiety, post-traumatic stress disorder, pre-existing disabilities, or exacerbated medical conditions, and a multitude of environmental stressors. Both SUD and DV increase risk of sustaining a brain injury, and some estimates indicate approximately 41% of female DV survivors and 14% of male survivors experience some form of physical injury. This is very important because for individuals that have sustained a brain injury, risks then related to substance use include potential exacerbation of motor, cognitive, emotional, behavioral impairments, potential disruptions in their cognitive recovery. They'll be at increased risk for seizures and further brain damage, and there's a risk of interactions between substances and current medications. This slide utilizes data from the SAMHSA key substance use and mental health indicators in the United States from the results from their 2017 National Survey on Drug Use and Health. There's often significant overlap with the diagnoses we're discussing in today's presentation, and as the number of diagnoses that occur simultaneously increase, impairments in day-to-day functioning typically increase as well. Chronic pain, SUD, and mental health conditions such as depression are common co-occurring disorders among individuals living with TBI. These conditions may have been present prior to a TBI, they may be a contributing factor to a TBI, or they may develop or worsen after a TBI. While prevalence rates for SUD among DV survivors often vary in studies due to the types of substances studied, definitions of SUD used, and where the sample was obtained, such as DV shelter residents versus a national survey, the data overall indicate a high prevalence of coexisting DV and SUD. The Massachusetts Department of Public Health, on behalf of the Division of Sexual and Domestic Violence Prevention and Services, has been able to provide data to us for the purposes of this presentation. This data examines binge drinking among youth who have dated in relation to dating violence and gender. Data indicate that on average, between 2013 and 2017, 6% of youth who had dated reported having experienced dating violence in the past year. 7% of female youth and 4% of male youth reported having experienced dating violence in the past year. Results confirmed that female youth were statistically significantly more likely than male youth to have reported past year dating violence victimization. Among youth who had ever dated, youth who had experienced dating violence in the past year were more likely than youth who reported no past year dating violence to have engaged in binge drinking in the past month. These differences were significant for youth who had dated overall and for both male and female youth who had dated. Among youth who had ever dated, but with no reported past year dating violence experience, male youth were more likely than female youth to report binge drinking in the past month. Binge drinking was defined as reporting any days in the past 30 in answer to the question, during the past 30 days, and how many days did you have 5 or more drinks of alcohol in a row, that is within a couple of hours. In the next section, we'll provide an overview of traumatic brain injury. The majority of traumatic brain injuries are actually mild TBIs. These injuries are typically associated with either no loss of consciousness or possibly a brief one. They may involve an emergency room visit for evaluation, but if neuroimaging such as a CT scan is performed, findings will usually be negative, as in the test results are normal. A moderate to severe TBI typically includes a longer period of loss of consciousness and a hospital stay with potential inpatient or outpatient rehabilitation following. In head injury, a coup injury occurs under the site of impact with an object, and a contra-coup injury occurs on the side opposite the area that was hit. After a traumatic brain injury, contusion, bruising, and bleeding can occur anywhere in the brain. Specific sites of bruising and bleeding can occur at the site of the blow to the head, as in a coup injury, and the site directly opposite the blow, as in a contra-coup injury. If something is described as a coup contra-coup injury, then contusions are both at the site of the impact and on the opposite side of the impact, or the opposite side of the brain. This can occur when the force impacting the head is strong enough to cause a contusion at the site of impact and sets the brain in motion, resulting in an impact with the opposite side of the skull, and an additional contusion, as shown in these images. In a whiplash event, injuries can be caused solely by acceleration or deceleration in the absence of a direct impact. For example, a restrained driver in a motor vehicle accident can sustain a brain injury without striking their head directly, but rather due to the force of the whiplash event. Similarly, survivors of domestic violence may sustain brain injuries when shaken violently, or pushed, or kicked with significant force, even without a direct strike to their head. The next two slides indicate a variety of symptoms that can be present in mild TBIs or concussions, as they are commonly referred to. Headache, dizziness or vertigo, feeling off balance, and nausea are common symptoms. Individuals may also have visual symptoms such as blurred vision or sensitivity to light, as well as auditory symptoms, including ringing in the ears or sensitivity to sound. Sleep disturbance may also occur. Vomiting typically occurs with more severe concussions. Symptoms may also include irritability, mood swings, fatigue, difficulty sustaining attention, and memory problems secondary to attention problems. What that means is that it's not a primary memory problem, but rather the person has memory impairment secondary to the attention difficulties. So for example, if someone introduced themselves and you weren't paying attention when they said their name, it's not a primary memory problem if you can't recall their name, but it's actually secondary to being inattentive to the information in the first place when it was presented to you. For more moderate and severe TBIs, there's typically a longer period of loss of consciousness. We also see cerebral contusions or bruising and bleeding in the brain that results from tearing of small blood vessels. Cerebral edema may also be present. Edema is swelling caused by excess fluid in the body's tissues, and cerebral edema is swelling in the brain. Brain swelling can lead to damage by disrupting the flow of blood and oxygen to the brain. Very severe swelling can cause death by compressing the brainstem, the part of the brain responsible for regulation of heart rate, breathing, and consciousness. Diffuse axonal injury, or DAI, is the shearing or tearing of the brain's long connecting nerve fibers due to shaking or a strong rotation of the head by physical forces such as with a car accident or a physical assault. As we reviewed on the slide for coup and contra coup injuries, DAI occurs when the unmoving brain lags behind the movement of the skull, causing nerve structures to tear. This slide illustrates a process called axonal shearing. When the brain is slammed back and forth inside the skull after a head trauma, it is alternatively compressed and stretched because of its soft gelatin-like structure. The long, fragile axons of the neurons or brain cells that make up the brain are also compressed and stretched. If the impact is severe enough, axons can be stretched until they are torn. This is called axonal shearing. When this happens, the neuron dies. An injury with substantial axonal shearing is more diffuse, spread throughout the brain. Axonal shearing cannot be directly treated at this time. On this slide, we have an illustration of a contusion in the frontal lobe part of the brain. The brain's violent slamming against the bones of the skull can result in a contusion or bruising and bleeding in the brain. This results from tearing of small blood vessels. It can also result in the death of neurons and is the second leading cause of neuron death. Small contusions, those which may be found in a concussion, are usually not treated unless blood flow is interrupted, as these are likely to heal on their own without medical intervention. In our next section, we're going to discuss consequences of brain injury and strategies or accommodations for working with individuals. The next video clip that will be shown is the video of a brain injury survivor who shared a story with the Brain Injury Association. He sustained a moderate to severe brain injury as the result of a car accident.
My automobile crash occurred on January 3rd of 1994. Of course, no memory and all of that, but I was told that. And I was 25 years old, and I sustained a traumatic brain injury in the right side of my head. So the left side of my left side of my body suffered nerve damage. So the major issue for me, all along has been for me, is my brain injury has caused my memory to be, it's functional, but a major pain. It's hard for me to remember things. I have to repeat things over and over and over to myself or aloud or whatever to remember them. I can't just look at something and remember it. A friend that I had been living with at the time of the accident was with me in the car. And he didn't live in that accident. I didn't know that. They told me that in the hospital 5 months later after my accident. And I think him, of course, every single day, pretty much all day long. And I just remember waking up at Fairlawn. I mean, I had to learn how to walk, talk, swallow liquids again, use my body and everything. Fairlawn is the place where I started my life after my brain injury. That's where I woke up. So that's where my life and that's where my life started. Because I cannot remember the first 25 years of my life now. I was hurt when I was 25. The first 25 years of my life are all very, very blurry, foggy to me. So Fairlawn is where my life started, and Fairlawn is a very special place in my heart. And you do things much, much, much slower after a brain injury because you kind of have to. Your body has to, your mind has to. It's a blessing in one way because you see how you appreciate everything and you see how incredible life really is. You don't just take things for granted. You work your butt off for everything. You take nothing for granted and you appreciate everything. It's so very thankful all the time. So.
The consequences of brain injury can fall into several categories, including neurocognitive deficits, physical disability, sensory impairment, and neurobehavioral or psychiatric symptoms. There are a wide range of neurocognitive impairments that an individual may experience, and these will be discussed in further detail in the next few slides. Individuals with cognitive changes following a brain injury may be less aware of their cognitive and behavioral limitations than their physical limitations. Physical changes caused by brain injury may be more visible than cognitive and/or behavioral changes, but many of the symptoms of brain injury are not visible. All senses may be affected by a brain injury, producing changes in hearing, vision, taste, smell, and touch. Changes may involve an increase, decrease, or loss of sensitivity. Changes may be temporary, as you may see with a concussion, or permanent with more severe brain injuries. For DV survivors experiencing a brain injury, the cognitive, physical, or emotional consequences of the brain injury can adversely impact their ability to live independently, their ability to work or attend school or job training programs, may impact their ability to care for children, access services, and it could potentially impact safety planning or assessing a dangerous situation. As we noted, there are various areas that can be impacted by a brain injury. These include, but are not limited to, domains of attention, learning and memory, visual spatial skills, or the ability to identify visual and spatial relationships among objects, cognitive linguistic skills such as reading and writing, executive functions such as planning, organization, and self-regulating, and language skills. The following are disorders of attention and arousal. Hypoarousal and persistent lethargy is more than just fatigue, and typically something we see with more severe injuries. It may present as significant inattention, apathy, or boredom as well. Individuals may also have difficulty sustaining concentration or dividing their attention. Neglect of left or right visual fields is another impairment seen with more severe injuries and is a poor prognostic sign after brain injury. Distractibility can be a common symptom and present from mild to more severe brain injuries. The following strategies may be helpful for disorders of attention or arousal. It can be beneficial to use verbal or physical cues to remind the individual to focus and help them learn to identify when they are losing focus. Reducing or minimizing distractions in the environment, such as decluttering space, can also help improve focus. When working with individuals, it can be helpful to shorten tasks and sentences, reduce information to the basics, and provide it in shorter chunks of information. During discussions, take breaks to summarize key points and ask the individual to repeat back important information or tasks throughout the meeting. And next, we'll have another video clip from a brain injury survivor highlighting memory difficulties and impact on caretakers.
My brain injury happened the day after my 17th birthday. I was coming home from a baseball meeting at my high school. As we were going around the corner, my friend looked down to finish a text message on his phone. He didn't see the corner and he missed it. And when we were going around the corner, I believe I yelled and shouted out and told him to hit the brakes. Instead of stepping on the brakes, he stepped on the gas. We slipped on a patch of ice or snow on the ground and went headfirst into a tree. And then I got out of the car, called my mom, and I had, I guess, strokes when I first stood up from the car, and I dropped into a coma right then and there.
When we got there, by the time we got there, he had already lapsed into the coma. He had 5 strokes on the way to the hospital. And that's how he severed his optic nerve.
I'm blind 100% now.
When we got there, his pupils were fixed and dilated, and he was non-responsive. And that's not the kind of words you want to hear.
When I go to do something, I'll do the same task probably a couple times, and then I'll realize I did it the first time, and then I'll be like, oh, damn it. And then, you know, this stuff, you just keep redoing it, and you already did it. Just checking yourself. My mom had to quit her job and start taking care of me every day.
Because I really don't like to leave him alone because he doesn't remember.
Yeah.
If I've gone somewhere, he doesn't know where I am, so when I leave, he'll call me or text me, and so it ends up being, so I just don't like leaving him alone, because if he goes out and gets the mail and ends up across the street at the neighbor's driveway and I'm not here, then he's standing outside and doesn't know where he is to get back home.
Yeah.
So I just never feel comfortable leaving him.
I'm still me. It doesn't matter. I do the same stuff I used to. I like doing the same stuff I used to. I'm still the same person I was. I just have a brain injury. It may take me a different way of doing something, but I'm still going to get the job done that you asked me to do. So.
Memory refers to the process of organizing, storing, and recalling information, and individuals with brain injuries may experience impairments in any or all of these areas. Post-traumatic amnesia is also noted here. That refers to a state of confusion that occurs immediately following a TBI, in which the injured person is disoriented and unable to remember events after the injury. There are 2 types: retrograde amnesia, or loss of memories that were formed shortly before the injury, and anterograde amnesia, or problems creating new memories after the injury occurs. Memory impairments can be particularly problematic for individuals experiencing domestic violence, as it can impact their ability to report incidents, particularly immediately following incidents when acute symptoms and confusion may be present. It can also impact an individual's ability to remember safety plans or remember shelter or program rules, potentially jeopardizing services or emergency housing situations. Strategies for assisting individuals with memory impairments include helping them develop a memory or organization system. Key to this is really finding out what works for this individual, what they've tried, and what has or hasn't worked for them in the past. You can encourage repetition for new tasks and consistent routines. Memory books, calendars, and phone apps are all tools that may be useful, and that assist them with practicing writing down key information when meeting and planning with them. Again, repeating information and reviewing frequently as needed. Disorders of processing speed may present as slow or impaired decision-making time, slower response time such as delayed answers to questions, and decreased reaction time and difficulty comprehending information in a timely manner. Strategies for assisting individuals with processing speed impairments may include presenting information more slowly and providing ample time for individuals to complete tasks. It's important to try to be patient for responses and try not to jump in and answer for the individual while they're still trying to communicate with you. It's important also to watch for frustration or the person being overwhelmed by the information you're sharing, and again, take breaks as needed during meetings. Shorter, more frequent sessions can often be helpful if that's something that's feasible. In the next video clip, we have an example of an individual who had a stroke with resulting language deficits that can also occur with TBI.
We have a Saturday routine. I lost my mother in 2007 of cancer, and my father and I stayed home with my father, and my father and I had a routine. I would clean the house, and he would go food shopping, and I was out in the porch, glassed in porch, and I felt my arm. Then my mind became almost like mush. I was thinking of words, and then I think of another word, and I have these thoughts, but none of them would coagulate into a sentence. Not speak, or if you do speak, it won't be clear. And that's how I realized that I had aphasia, and the doctors left, and I looked at the nurse, and the nurse says aphasia is, and she explained it to me. Therapy, I saw a picture, and I couldn't identify a cat, couldn't identify even my own dog, Maggie, and it was so frustrating. It was like, just kill yourself, this is terrible. And then my speech therapist said to me, just go with it, you'll be fine. Aphasia is the inability to speak. It diminishes your cognitive abilities, it diminishes your organizational skills, it diminishes your long-term memory, your short-term memory, it diminishes your ability to understand people and to recognize things. I was in speech therapy at Norwood. I would draw a line for every syllable of every word. And after a while, I said to myself, socially, that would be repugnant. So I started moving my hand, and once I got the rhythm, I was able to speak with people. There are people who I've been called retarded. I was actually told by a waitress in a restaurant to leave because it was disturbing the people across. Some people in the family have actually had to have tried to have me declared incompetent because I moved my hand. I can't talk. She can't talk without moving her hand. The BIA of Massachusetts is very informative. It is probably one of the best way to research brain injuries and aphasia.
Disorders of language often result from damage to portions of the brain that are responsible for language and most commonly occur after a stroke, but they may also be present after head injury. These disorders may impact an individual's ability to speak, write, or understand language. They may experience difficulties with word finding, naming, articulation of speech, or verbal fluency. Impairments may impact production or comprehension of language, both verbal and written. Generally speaking, language impairments are often seen with more severe injuries. There can be significant functional implications, as an individual may not want to use a phone and may be less likely to ask questions to clarify information. For individuals experiencing significant communication deficits, it's really important to follow up with a speech and language therapist or to encourage recommended speech and language strategies if an evaluation has already taken place. Additional strategies include encouraging an individual to take their time while communicating with you, articulating, and providing cues or gestures if that's helpful for the individual. It's really important to start by asking them what they find helpful. As mentioned previously, it's important to give someone time to respond, And by having a discussion, you can attempt to find that balance between giving someone adequate time to respond and also finding out when and under what circumstances it might actually be helpful for you to provide them a cue and that they would like that. It's also great to utilize written communication or assistive devices if that's appropriate as well. Pragmatics might be another thing that may be challenging for some individuals. This is really knowing what to say, how to say it, and when to say it. So these individuals may benefit from social language skill, building by practicing social conversations, turn taking, making a point, staying on topic. Providers can really assist by setting topic boundaries, cueing, modeling appropriate responses, and helping the individual practice responses for specific social situations that might come up. Disorders of executive function and self-regulation skills may also be present following brain injury. These disorders may include impairments in initiating or sustaining activity, impairments in sequencing, planning, organization, and difficulties with problem solving. These individuals may also exhibit poor safety awareness, difficulty identifying emergency situations, poor insight, and poor judgment. Strategies for executive function impairments may include an emphasis on schedules and routines. And this strategy has been recommended for various difficulties so far because it's very important and very beneficial for cognitive and behavioral difficulties. It's also beneficial to have clear and concrete and concise instructions. And when working with individuals, it's important to establish boundaries and to model appropriate social behaviors and interactions. You can assist them with trying to take a different perspective and potentially imagining another's point of view in a situation. And then it's also good to be aware, though, that there may be some challenges for an individual to generalize from one thing to another. Again, it's beneficial to develop some safeguards related to any issues related to poor safety awareness. There's a wide range of behavioral and psychiatric symptoms that may be present with TBIs, but sometimes those symptoms were present before the TBI and have worsened. Sometimes those symptoms are new and resulting directly from the brain injury. And sometimes those symptoms are secondary to the adjustment and new stressors related to living with the brain injury and resulting consequences. While depression and anxiety may be common following a brain injury, significant aggression or psychotic symptoms are much less common and something we typically see with much more severe brain injuries. I do want to highlight the risk of multiple brain injuries. There are risks associated with experiencing multiple brain injury in one lifetime, and an increased length of stay in a relationship with DV increases that risk of experiencing multiple TBIs. Second impact syndrome is a rare event that happens when a second brain injury occurs before an individual has had sufficient time to heal from an initial injury or a first injury. This results in rapid and usually fatal brain swelling. And while this is a rare event, when it does occur, the condition is often fatal or results in very severe impairments if an individual does survive. These incidents have been most commonly reported in football, but given the high risk of untreated injuries and repeat assaults that can occur in very close proximity in DV situations, there's definitely a potential risk in this population. Chronic traumatic encephalopathy, or CTE, is a progressive degenerative disease of the brain found in individuals with a history of repetitive brain trauma. You may have heard about this in the media related to boxing and football. Both second impact syndrome and CTE have been primarily studied in athletes and post-mortem brain studies, but additional research is needed to examine the long-term effects of DV on brain health given the noted risk of repeat injuries. In the following section, we'll briefly highlight the continuum of service needs for individuals with brain injuries. Treatment needs for individuals who've experienced a brain injury can generally fall into the following categories: acute services, post-acute interventions, and ongoing treatment needs. Acute interventions are active but short-term treatments, typically focused on urgent needs related to the brain injury or recovery from related surgeries. Interventions may include emergency department evaluation and services, specialized inpatient care, such as placement on a trauma unit, and evaluation and treatment by medical specialists related to type of injury, such as neurosurgeons or neuro-oncologists. Post-acute interventions may include inpatient or outpatient rehabilitation, including speech, language, and cognitive therapy, physical therapy, and occupational therapy. Individuals may be placed in a skilled nursing facility or long-term care facility if they are in a coma, are slow to recover from their injuries, or they're experiencing a progressive disorder. If someone continues to have significant impairments following acute interventions and are currently homeless, they may also end up in a SNF or a long-term care facility. Community-based supports are additional post-acute interventions. They include things like VNA services or home health care. Individuals with brain injuries may continue to have various ongoing treatment needs following that initial evaluation and intervention period. Neurology follow-up or ongoing monitoring may be necessary for neurodiagnostic testing, to rule out seizures, for differential diagnosis with complex conditions, or for evaluation of a shunt status. The shunt is commonly used to treat a condition called hydrocephalus that can occur with brain injury, swelling of the brain due to excess buildup of cerebrospinal fluid. Shunts require close and ongoing monitoring. Neuropsychologists may also be utilized for assessment of neurocognitive impairments, which may compromise functioning, for treatment goals and objectives, and documentation of accommodation recommendations for school or work. Neuropsychiatry may be utilized to assess mental status changes, medication evaluation, and recommendations. This specialty area can be particularly helpful for individuals with duly diagnosed brain injury and mental health conditions. Individuals may also benefit from additional rehabilitation services, including physical therapy, occupational therapy, and cognitive rehabilitation. Additional specialized treatment, such as interventions focused on substance use disorders or emphasis on trauma-informed care, may also be beneficial. Community-based support and services can be an essential part of assisting individuals and maximizing their independence in the community. Educational and vocational services can support educational goals and obtaining and maintaining employment. Avocational services may include day programs, volunteer opportunities, or clubhouse settings, which can improve social engagement and provide some daily or weekly structure. Community living supports may include personal care services, support living, or 24/7 residential settings. Safe and affordable housing is another integral support need that may be a necessary first step before individuals can pursue additional goals and access a variety of other services. Additional community-based support needs may include community integration, including access via transportation. Case management services may include advocacy, linkage to resources, and coordination of medical care. In addition to day programs or clubhouses, there may be other program opportunities for social or recreational activities that include group social trips or other types of activity clubs. Assistive technology can support individuals with challenges in learning, communication, or functional or physical impairments. This can range from low-tech paper communication boards to high-tech computers or equipment. Lastly, support services for family members or significant others can be highly beneficial, whether this comes in the form of respite care to provide short-term relief to caregivers or support groups such as those offered by the Brain Injury Association. In our final slides, we'll note considerations for individuals experiencing brain injury and domestic violence. There are multiple ways that DV can impact brain injury evaluation and treatment. First, there is a risk of underreporting injuries. We understand that survivors are unlikely to disclose potential injuries in the presence of a partner who perpetrates violence, so there will be an impact of reporting differences with that partner present during police or medical interviews. Even if the partner isn't present, though, the survivor still may not report if they're still living with the partner or potentially out of fear of DCF involvement. Compared with non-DV related brain injury populations, these individuals may not seek medical attention due to shame or fear, placing them at risk of untreated repeated injuries. There is also a potential lack of social supports in a DV who perpetrates violence and possible isolation from the community. Individuals with brain injury may have a partner and possibly family supports. There is an impact of brain injury on DV evaluation and supports as well, including potential cognitive impairments contributing to difficulty reporting DV and possible memory problems and confusion, particularly immediately following incidents, when acute symptoms may be present. Individuals may have more difficulty accessing services, assessing danger, making and remembering safety plans, and adapting to living in a shelter where they may become anxious, confused, or have difficulty understanding or remembering shelter rules or guidelines. There is a strong potential for DV survivors with brain injuries to be undiagnosed or misdiagnosed in mental health or medical settings. Brain injury symptoms are frequently misdiagnosed as PTSD or depression. Comorbid brain injury and PTSD symptoms may be misunderstood as resistance to treatment or mistaken as personality features. There can also be significant barriers in criminal justice and legal settings, as these individuals may unfairly be seen as unreliable, potentially impacting child custody, restraining orders, and criminal proceedings. Specialized training for court personnel regarding the issue of brain injury, DV, and PTSD is essential in attempting to counter some of these barriers. Judges, lawyers, advocates, and court officers would all benefit from increased awareness in this area. And now I'll turn it back to Gabby, who's going to just briefly mention part 2 of the training series.
Thank you, Dr. Insalarco. So I would like to invite you all, if you like part 1, come back for part 2, where we will be diving into some of the screening for brain injury options. We will teach you how to make accommodations for individuals living with a brain injury and show you how it can enhance your relationship with these individuals, as well as help them follow through with services and recommendations. We will also go over some of the places where you can go within Massachusetts for brain injury resources, as well as cover some of the safety planning considerations when working with this population. Next slide. Should you have any questions between now and then, or want to learn more about the statewide head injury program, this is our contact information over at the Massachusetts Rehabilitation Commission. Next slide. These are our references for this presentation. Next slide. Next slide. Next slide. And we would love to wish you all a great day. Thank you.